Physiological Functioning Part 2. Physiological changes in the gastrointestinal system include a decreased need for calories, along with a decreased appetite, thirst, and oral intake. We also see a decreased lean body mass. We see digestive disturbances and a decreased stomach emptying time. There is a decreased absorption of carbohydrates, proteins, fats, and vitamins, with an increased tendency toward constipation and susceptibility to dehydration. We also see tooth loss and difficulty with chewing and swallowing food. In the esophagus, we see GERD, the gastroesophageal reflux disease, and hiatal hernias. And also in the mouth, we see taste buds declining in number, with the gums becoming more susceptible to periodontal disease, and a decrease in salivary secretion. In the stomach, we see anorexia or weight loss, with an increased susceptibility to peptic ulcer disease. The stomach will decrease production of the intrinsic factor, and peristalsis is now slowed down. The intestines, the villi, become shorter, and constipation is more common because of this. Liver function tests are unaltered, and we see an increase of incidence of gallstones, along with serum cholesterol levels increasing. So considerations: we need to encourage routine bowel habits. Diets should be adjusted to encourage healthy bowel evacuation, and stool softeners should be considered because they may be beneficial. Nursing actions: encourage good oral hygiene, properly fitting dentures, prompt treatment of dental caries and periodontal disease, appropriate amount of time for meals in a relaxed atmosphere, and maintenance of an adequate intake of fluids. Make sure that you provide enough time for response to gastrocolic reflux, and encourage prompt response to the urge to defecate, along with a balanced diet and dietary consult as necessary. Avoid prolonged periods of immobility, and discourage smoking, and provide smoking cessation education. With the reproduction system, physiological changes seen in women include the labia majora and minora becoming less prominent, along with thinning pubic hair. Breasts will become smaller and less firm, and estrogen levels begin to decrease. We see a decreased secretion of hormones with cessation of menses, and vaginal changes will include a decreased muscle tone and lubrication. With men, the testes begin to atrophy and soften. Ejaculation is slower and less forceful. An enlarged prostate can lead to urinary problems, and we also see decreased testosterone production. For both genders, impotence and/or sexual dysfunction is common. Sexual function can vary and depends on general physical condition, mental health status, and medications. Considerations include many elderly couples remain sexually active. Medications are available to assist with impotence issues, and decreased secretion production may necessitate moisturization products. Actions: do not discourage appropriate intimate relationships, and in long-term care facilities, be certain to respect a couple's privacy. In the nervous system, some disorders would be cerebrovascular disease, which can be an interruption of blood flow to the brain. It is the third most common cause of death. 75% of strokes occur in adults that are 65 years and older. We see it as being ischemic or hemorrhagic. Ischemic CVAs may be caused by narrowing or blockage of arteries, an embolism, coagulation disorders, and systemic hypoperfusion, such as dehydration, hypotension, cardiac arrest, or syncope. We also see TIA, or transient ischemic attack. It used to be considered temporary, but the newest definitions from some of the most recent literature that's out are now saying that TIAs are tissue-based and not time-based. It requires prompt treatment and is considered to be an emergency, such as a CVA. Treatment will require antiplatelet agents. TIAs are more prevalent in males and African Americans. And then we have the full-blown CVA, or brain attack, and it also is definitely an emergency. The next nervous system disease is Parkinson's. This is a movement disorder and can be mimicked by some medications. It's slightly more common in men than it is in women, and we see a lot of resting tremors and pill rolling with increased rigidity of muscles, stooped appearance, and a flexed neck with a tendency to fall backwards. Impaired communication, such as aphasia, will affect the ability to communicate and understand reading, writing, or gesturing. And dysarthria is the other impaired communication that's caused by weakness or incoordination of the speech muscles. So we often see slowed or slurred speech. Decreased sensitivity results in delayed reactions to things. So we see slowed reflexes, slight tremors or difficulty with fine motor movement. We may see a loss of balance and an increased risk for injury. An increased incidence of awakening after sleep onset. As people begin to age, they begin to spend more time in bed in order to get the same amount of sleep as they did when they were younger. We see an increased susceptibility to hypothermia and hyperthermia. Memory impairments or difficulties are common. The short-term memory usually declines, but the long-term memory is usually maintained. And the brain will begin to decrease in weight and size. So nursing considerations. Decreased nervous system changes can affect self-esteem and confidence, and we have to remember this. Nursing actions: assess the need for and provide safety measures, and allow additional time for recall and provide reassurance. Excuse me. This slide can show the decrease in weight and size of the brain as we age. In our special senses, we see changes in these senses, especially vision, that can negatively affect the quality of life. Physiological changes: eyelids will begin to lose elasticity and droop, and color perception decreases. Lower eyelids begin to turn out. We see dry eye syndrome as being common, with a decreased visual acuity. We often see near vision decreasing and the lenses begin to thicken. We see decreased accommodation in the eyes, which requires increased time for adjustment to changes in light. Common causes of decreased vision in the older adult include decreased peripheral vision and an increased sensitivity to glare. Macular degeneration is a big cause of decreased vision. It's the leading cause of vision loss in Americans that are 60 years and older. It starts out with blurred vision, difficulty reading and writing, an increased need for bright light to see, dimming colors, and progressive loss of central vision, leaving only the peripheral vision. Causes include genetics, smoking, obesity, and excessive sunlight. Cataracts is the clouding of the ocular lens, and it's caused by oxidation damage to the lens protein and fatty deposits in the ocular lens itself. It's more common with exposure to excessive sunlight, poor diet, hypertension, kidney disease, eye trauma, history of alcohol, and tobacco use. Yellow and dark leafy vegetables and vitamin E can decrease the risk for women. And cataracts can be treated with surgery when certain parameters are reached. In other words, the cataract has to grow to a certain point. Glaucoma. We see natural fluids of the eye that are blocked by ciliary muscle rigidity, and this causes intraocular pressure to build with damage to the optic nerve. Causes can be variable and frequently are unknown. We treat them with eye drops, oral medications, and potentially laser eye treatments. Diabetic retinopathy is a leading cause of blindness. Complication of diabetes is caused when blood and lipid leakage leads to macular edema and hard exudates. So we look at strict control of blood glucose, cholesterol levels, and blood pressure because these can slow the disease. Laser treatment may be helpful along with annual eye exams beginning 5 years after the diabetes diagnosis. Dry eyes. This isn't a disease, but it is a common complaint of older adults. Causes would be medications, and we treat these with artificial tears, home humidifiers, and avoiding wind or hair dryers. Presbyopia is an age-related situation that causes a decrease in near vision, and it begins to become noticeable in midlife. There's also a possibility of loss of hearing ability. Low-pitched tones are going to be the tones that are heard more easily. It is the third most chronic condition of the older American adult population, with 90% of Americans over age 80 having some type of hearing loss. It will increase feelings of isolation. It is underdiagnosed and undertreated. Some medications can be ototoxic, such as gentamicin and vancomycin are two of the more common ones. The types of hearing loss will be conductive, which are abnormalities of the external and middle ear. It reduces the ability of sound to be transmitted to the middle ear. It's caused by otosclerosis, infection, perforated eardrum, fluid in the middle ear, cerumen accumulation, with cerumen impaction being the most common and easily corrected situation that interferes with hearing in the older adult. So if there is a decrease in hearing, always look for impaction of earwax. Sensorineural loss is caused by damage to any part of the inner ear or neural pathways to the brain. Presbycusis is what we term this. Tinnitus is the perception of sound with no sound present, such as ringing in the ears, and it may involve conductive or sensorineural. It's caused by exposure to loud noises. And as we begin to age, earwax becomes more thick and dry. We also may have an inability to discern tastes of foods, a decreased smell acuity, and changes in touch sensation and decreased pain awareness. Considerations. We need to place clients in an area where the volume of the television is going to be appropriate, the radio or lighting is appropriate, etc. Enhance hearing with hearing aids, cochlear implants, listening adaptive devices. Decrease other noises by shutting a door or a window, Speak in lower tones. Make sure that you stand in front of a client at the client's level. Warm incandescent lighting, shades or blinds to help control glare. Yellow amber lenses to decrease glare. Large print. Avoidance of reds and oranges because of the low contrast. Use of a magnifying glass or possibility a talking watch or clock may be beneficial. Actions can be providing for safety. Discourage exposure to excessively loud noises, avoiding injury with cotton-tipped applicators and other cleaning materials. Encourage the client to see healthcare providers promptly if there's a sudden change in hearing or vision. Encourage protection of the eyes from ultraviolet light. And discourage eye strain, and the use of a bright light should be used when needed. Endocrine changes. We begin to see glands atrophy with a decreased secretion of hormones with specific changes related to each hormonal function. For example, hypothyroidism risk will increase in the older adult because of a lack of production of the thyroid hormones. The liver decreases in size and weight, as well as the total hepatic blood flow. Surgical intervention for disease of the biliary tract is the most common operative procedure performed in the elderly. In other words, cholecystectomy. Cholesterol saturation of bile increases with age because of increased hepatic secretion of cholesterol and decreased bile acid synthesis. We begin to see a decreased metabolic rate, decreased glucose tolerance. With diabetes mellitus, we have to remember that physical fitness is essential, even if that activity is chair exercises, because that's better than no exercise to assist in maintaining blood glucose levels. With the pancreas, again, diabetes is the leading cause of end-stage renal disease and blindness in clients that are over 65 years of age. We see a decrease in wound healing due to diabetes, increased depression, increased sexual dysfunction, and these clients often die from heart disease. Type 1 diabetes is immunological in origin. Type 2 is very common in the older adult. The third type of diabetes is related to long-term or acute steroidal use and is seen in the older adult. Thyroid disease. Women are going to be more likely to suffer from thyroid disease. Hypothyroidism is the most common thyroid disturbance in older adults, and we see it a slow onset. With hyperthyroidism, Graves' disease is the most common cause in the older adult, with goiter formation, and we see hyperthyroidism with a sudden onset. Hematology and immune systems. A couple of things to remember is oral temperature is going to be lower in the older adult, and immunoglobulins will increase with age. Again, pain sensation is going to be altered as we age. Pain and pain medications, we have to remember, are going to be the most common, or going to be some very common sources of confusion in the older adult. So always assess pain levels when you are assessing a new onset confusion. Infection concerns can be very typical in the older adult. And these are a list of nonspecific symptoms that may indicate an infection. So in the older adult, our bodies tend to react differently to pain and to infection. So we always need to be looking at some of these status changes with those things in mind.